Oh, we're live. Cool.
All right. Hold up, it's loading a little bit. All right. How you doing, everybody? Thank you for joining us. I just have a couple announcements before we start. First, join our email listserv on our website for updates on our newsletter. Also, make sure to add us on LinkedIn and list this as one of your experiences. And also make sure to follow us on Instagram if you haven't already. And just a reminder that you have 48 hours to complete the journal entry / quiz after this, because we know how busy you guys are with online classes and everything like that. Now, to introduce our presenting physician, Dr. Jenny is a interventional radiologist at the at the Icahn School of Medicine at Mount Sinai. She completed medical school and her undergrad studies at Vanderbilt University, while also completing a PhD in chemical and physical biology. She also has an amazing Instagram account where she constantly posts super interesting, informative posts about an array of science and health related topics. We're going to link that in the chat, and it's also linked in our Instagram post if you want to go check that out. I always have a lot of fun and learn a lot from those, so I hope you guys will too. But without further ado, Dr. Jen, you can take it away.
All right. Thank you so much. It's good to be here and to speak with you guys. And I'll just get started. So I understand the audience is mostly undergraduates and excuse me. And so I wanted to start broad and take you through like a day in the life of what being an interventional radiologist is. I'm a resident. I've been involved in interventional radiology for number of years, maybe 5, 6, 7 years, and I'm a second year resident in an integrated interventional radiology program. So so the goals of today would be to give a brief introduction to the field of radiology and interventional radiology, take you through a day in the life that will include some cases, briefly touch on my journey into medicine and radiology, a bit about what radiology looks like after training, because right now we're all focused on all of this training, but when you think about it, you have so many more years of actually being in the field practicing. And then my main goal is to convince at least one of the people who watch this to consider a career in radiology, and more specifically interventional radiology. So I hope I can convince you how awesome of a field this is, and let's get started. So what is interventional radiology? It's a question that I get a lot, even from, older physicians and, people who maybe aren't in big academic medical centers. They're like, what exactly, I've heard of it, or I send patients to you guys, but what exactly do you guys do? And it's highly varied. But in brief, it's a medical specialization that involves performing a range of image-guided procedures. So we interpret the images, we can diagnose pathology with the images, and then we can intervene on them using imaging-based methods. So let's talk about radiology and interventional radiology. They actually are pretty different things, but many people do both. They're both image-based specialties. So this is my interpretation. So radiologists, I feel, are the front lines of diagnosing problems early and correlating medical imaging with other examinations, tests, clinical history. Interventional radiologists, we're board certified diagnostic radiologists, but we use minimally invasive image-guided procedures to diagnose and treat disease. You can absolutely do both. As I said, you're board certified. To be an interventional radiologist, you have to be board certified in diagnostic radiology. And people, end up with often doing a split 50-50 or 80-20. It just kind of depends on the practice you find yourself in. So I get this question a lot. Okay, like, why didn't you go into surgery? Or what's the difference between IR and surgery? It's could be said many, many different ways. But I would say we're a collaborative group of physicians. We work together all the time. And my interpretation would be that the primary difference between IR and surgery is that as interventional radiologists, we routinely utilize advanced imaging to guide interventions. Not to say that, surgeons don't, but, they would be who you might send for open repairs of abdominal, cancers, whereas an interventional radiologist would take a minimally invasive approach. Some patients are more appropriate for an interventional radiology treatment, other patients more appropriate for surgery. As I said, a very collaborative, experience between the two specialties if you're a patient. So let's just take you through a day in the life. So this is one of my bosses. I hope he doesn't mind using the picture. I mean, it's on Google. So we're a clinical specialty. So I don't know how many of you guys have, been in hospitals or gone on rounds. I know you're all undergraduates, and I definitely didn't have those kinds of experiences. But if you can kind of picture what rounds look like, going and seeing patients, that's what we do in the morning. So 6:30 a.m. we'll round on the patients. So those are patients we've done interventions on, are going to do interventions on, say hi, explain risks, benefits of surgeries, make sure they did well overnight. And as I said, we talk to all of the other teams because we are often a phone call away from surgeons who really need our help and to do something image guided. And so we're always talking to other teams, figuring out the best way to navigate a patient's hospital course. Then around 7:15, and this is, similar to many other specialties, when you're in training, I have didactics every morning around 7:15. We either have, we're either being taught or we have case conferences. It's public speaking and talking through cases and talking through what you did and why you did it is a huge part of residency in general and really part of being a physician. And so it's a great opportunity to practice public speaking. It's, I'm publicly speaking now. It's something that I'm, actively seeking to improve upon. And it's definitely something that, as radiologists and interventional radiologists, we do a lot of. I think sometimes people think of radiologists in general as people who don't talk too much, hang out in the basement, look at studies. We definitely sometimes work in the basement, no doubt, but we definitely do a lot of talking and teaching throughout the day. So let's say this is our first case. So this is a coronal view of a patient. So this probably looks totally foreign and that's totally normal, but I'll just point out, here's the liver, okay? Left is right and right is left. And here's a big vein, okay? And if I can show you, if you can appreciate the difference in brightness of these two areas, this is a clot, okay? We're not gonna get into the details, but this is a clot and this is something that on first case of the day, we're planning on doing. And this is something that is, perfect for what an interventional radiology does. We need to go into blood vessels, do minimally invasive interventions and help fix clots. So what does that look like? So we get into the veins, okay? You have veins and arteries. This is a vein. This blood is flowing back to the heart, and we take pictures. We use dye, and as you can see, the vein kind of stops. You can appreciate it stopping. There's not much to it. You don't see it kind of flowing back like you might expect. All I really wanted to show in this case, because was that, one thing we do, this is a balloon. I don't need to go into more detail than that. It's cool. You go in, you treat with a balloon, you open up that area, and then you get a good result. Then you take a picture and this really helps the lives of patients. And I'll show on the next slide kind of what an outcome would be of a case like this. So we're going to call this a venous thrombosis case. So something like this. You can imagine sometimes patients present acutely with these clots, sometimes chronically. They often have venous stasis or swelling of their legs, as you can see on the left-hand side here. And when you treat them and blood can leave their lower extremities better, you get a huge improvement if you achieve a good end result. And so this is just one of the types of cases that interventional radiologists do. Okay, so that was a scheduled case, okay? And then your pager goes off and you say, okay, someone's crashing in the emergency room. We need IR to come evaluate. We think they might need an IR procedure. So you're like, okay. You run to the ED. And what do we have here? We have a stat pulmonary embolism case. So I'll take you through some of the pathophysiology, but really I'm just going through these cases to kind of show you kind of the excitement and just hit on some, themes of what IR does. So this is an artery. And like we saw in the previous case, what's this? There's no contrast here. Contrast is bright. no contrast is able to go here. That's because there's a clot there, okay? And that clot got there maybe from the legs, most probably from the legs or another big vein in your body. It's a big problem for your circulation. You know, patients can, you know, acutely, faint or, have a cardiac arrest. There's an array of pathology that can go along with when you have this big blood clot in your lung. It's in the arteries of your lungs. And, you know, when I was in undergrad, I definitely was more focused on like the molecular and cellular level. I really didn't have a huge appreciation for kind of what went on inside the human body as much as I do now, of course. But especially, you know, I know you mentioned you're going to be a scribe, you know, knowing kind of some, knowing some general ideas of what these vessels are called, where they go, and what causes big problems, especially in the emergency room, I think is important. So these PEs, it's a really, big thing to deal with. And sometimes it's managed medically, sometimes surgically. And IR has a lot of emerging technology that's used to treat these. So you can just follow with me, people with a variety of risk factors get blood clots, okay? Blood clots travel through that vein, right? So this is deoxygenated blood going back to the heart. And this blood clot stops right here, okay? This is an embolus that's traveled through and gets lodged in the blood vessels of your lungs. So pulmonary, lungs, embolism. It moved from the legs up to your pulmonary arteries. So this little clot, it's only on one side here. On the previous picture, it's on both sides, but that's kind of the, overview of what a pulmonary embolism is. I'm not going to go into detail on this slide, but as I kind of was fumbling through before explaining is, when you have these, some people call it the pulmonary embolism death spiral. It's like, it can cause a cardiac arrest. It can cause heart problems that, independent of a cardiac arrest, your heart doesn't work right because you now have pressures in different areas of the heart that aren't used to having these increased pressures. And ultimately, you don't get enough perfusion and you get hypotensive. And so hypotension means your blood pressure isn't high enough, meaning you ultimately will have problems oxygenating parts of your body, most notably the brain, your heart. So those are cases that we run in for. We talk with many teams about, we get alerts about in our system when we have a positive case. And so these cases are diagnosed by diagnostic radiologists, of course, in conjunction with the clinical teams based on clinical suspicion. And then IR is often called to weigh in on if this would be an appropriate patient for an intervention. And so I think this is really cool. And I'm not sure if I would have thought this was cool when I was in college and didn't, have the appreciation I have now. But so this is, just another example of these huge clots, okay? You get in there with the catheter, and I'll show a little bit about this later, but it's really not the point of all this. You get in there and you can appreciate how there's, in both of these areas, there's barely any blood flow. At least, you compare that to this when it's declotted and you've taken all of it out, and that's what they're showing here on these gauze. These are literally huge clots that they're pulling through these catheters out of the pulmonary arteries that open everything up and really help these patients out in a really fast way. So these are really cool cases, and you can really even appreciate on the table patients who become more stable, who were unstable at the beginning of the case, meaning their vital signs really improved. This is just another example. So this is actually the anatomy of the pulmonary arteries. This is someone who, clotted presumably off multiple different areas of both of their lungs that they were able to pull out in a stepwise way. And then they formed it on the back table, but this is just representative of what you can do with small catheters using minimally invasive techniques. And of course, guys, stop me if there's any questions. I'm so happy to answer. Okay, so whoa. So we got another patient beat me. There's a stroke alert, okay? So, most of us have heard of strokes, but, another thing is, okay, so what do we do about strokes? And actually in the past, 6, 7, 8 years, the therapies to treat strokes have really evolved and now involve a lot of endovascular work. So work in the arteries that lead up to the brain. And without going into too much detail, pre-stroke on the left here. And, while if I was just showed this image, really what I want you to do is compare it to the other image when you see many, many more blood vessels open, okay? So this is someone who had a stroke. They went in, they took out a blood clot, similar, smaller, but similar to what I showed you in the prior case. And all of a sudden they reperfused their brain. So this person is now saved from all of that ischemic injury to the brain. And that's huge. These people also, I've seen it with my own eyes. They can't move half of their body when they're on the table. And this is a very dramatic example, but I have seen it. They can't move their arm when they're on the table and, they're plegic. You take out this clot that's affecting that part of the brain, and they literally start moving their arm on the table. It's truly unbelievable what these endovascular techniques can do, in my opinion. Okay, let's keep going on our day. Okay, so now we're back to some scheduled cases, okay? So I'll just take you through some, more schedulable type cases, the prior two were just emergencies. So this is a uterine artery embolization. In very broad terms, you have your uterus, so women, and you can get these fibroids, and these fibroids can be painful, they can bleed, they can really affect the quality of life of women. And, while hysterectomy or other interventions, myomectomies can help, having a minimally invasive option to help shrink these fibroids is emerging, and and really for many, many years has been an option that some women choose, especially if they want a fertility sparing intervention, but they still want to address their fibroids that are affecting their quality of life. So again, endovascular, in the vascular system, these are arteries. You go in an artery and you quite literally find your way with wires and tools and tricks into the arteries that feed these fibroids. You put in little beads that kill, that cause necrosis, that cause the capillaries to get clogged up, and those fibroids dramatically shrink. And this is an outpatient procedure. This is something that some IRs, almost do exclusively because there's a really high demand for these procedures amongst many women. And kind of in a similar vein, in terms of targeted treatment, there's targeted cancer treatment. So, we're not oncologists, but we work very closely with oncologists in deciding what patients would be most appropriate for targeted cancer therapy or transarterial therapy. Again, these tumors have these feeding arteries. You can put chemotherapy, you can put just beads that cause the capillaries to get clogged and kill the tumor. You can put radiation beads that quite literally emit radiation to kill that part of the area. And this is something we often do in liver tumors. So this is just showing a liver tumor with a big vascular arterial network. And then, in this cartoon on the other side shows how you can imagine if you get that catheter all the way out there, then you can inject chemotherapy and embolics to kill that tumor. It's a really cool case. And this is the last case I have, and then I'll talk a little bit more about some other things. And then the last case today I wanted to show was a Portacath placement. Do you guys know what a Portacath is? Ever had Yeah, so it's something you're definitely going to see when you start working in hospitals and when you're, medical students and later in life. And I hope none of you or your family members have to get this, but this is a device that is put underneath the skin into a vein in your neck to deliver chemotherapy. So in brief, the reason you need these is because not all chemotherapy can be taken as a pill or can be given in an IV in your arm. This is something that if you need to give the chemotherapy to a very big vein, you put this in. So this allows cancer patients to not have to keep getting IVs or large access in order to get their treatment. So this is, this would imagine this under the skin. So this is a pretty routine, I would call this, a bread and butter IR case would be a Portacath placement where you use ultrasound guidance, insert, via a stepwise approach, insert, a needle, a wire, and a catheter into the vein, and then you sew the port into the chest wall. Now, I say they're bread and butter. There's cases that are not bread and butter that are Portacath placements, but this is a typical outpatient case. Patients come in, they've just recently been diagnosed with cancer, they're going through a lot, and we as IRs, play a small role in their care sometimes, but it's, we can really take them under our wing, get them through their procedure, and now they have this access site, so they don't have to keep getting, IVs, and they can initiate their chemotherapy. I think it's a rewarding procedure to do. So I'm not sure if you're wondering, but you might be wondering, like, where are these procedures performed? What does the room look like? Like, what do my days or an IR's days look like? Okay, not all rooms have this purple lighting, but the general idea is this. You have to be wearing, lead glasses. Underneath here, they're wearing lead shields. This is radiation, okay, that's going through the patient in order to get these images. So you're injecting contrast into the patient, okay? And then you turn on the radiation and you can see, depending on where your tube is inside the patient, the structure you're looking at. So it's a very dynamic process. This arm, this part of the machine can move around. It's kind of like a robot, but you actually have to move it, but you move it around, get different views, and make sure that you're exactly where you want to be before you, let's say, treat a patient or blow, with an embolic or blow up a balloon. And so I wanted to address briefly, I'm, talking about tubes. I said the word catheter, things that, might definitely would have sounded foreign to me when I was an undergrad. But this is I just wanted to show you guys some pictures of kind of what we use day to day. This is definitely not comprehensive of everything, but I just showed you fluoroscopy. Okay, so that's using that machine, but we also use ultrasound machines all the time, especially at the beginning of cases. And we use CT scanners. It's actually what I've been doing all day, using a CT scanner to do cases in order to use that imaging guidance to find out what exactly we want to do. And then, this is an example of catheters. So these are hollow in the middle, and you put a wire through, and that wire with the soft end in conjunction with a stiffer catheter allows you to navigate through the arterial or venous system. And these come in a variety of shapes and sizes. This is a stent, okay? So this is if you want to open something that's closed or open something that's not completely closed, but stenosed is the word, is narrowed. You can put a stent in, and this is a balloon. So in that first case I showed that, you balloon open the veins. This is a balloon at the end of a catheter that you would then have a wire through, if you can imagine that. So my technical talk is essentially over, but I have some more background into kind of my path. But are there any questions right now about the cases or the layout of any of this?
We usually do them at the end, but we do have some questions involving the strokes and how you would interact with patients that have, different types of strokes or different severities of strokes as well.
Yeah, that's a really good question. So in brief, these patients, when they present, are assessed usually by a neurology team. They have, a number of scoring systems to decide if this patient, what the deficits of this patient are. They'll start with a CT scan. And on that CT scan, you can appreciate if there is blood. So if it's hemorrhagic stroke or if it's an ischemic stroke, ischemic meaning that there's, probably a clot somewhere in the brain vessels that's causing that brain to not be perfused, which is causing that stroke. So these interventions are for ischemic strokes, and most strokes are ischemic, or a large proportion of strokes on presentation are of the ischemic type. And based on a number of factors, this patient's risk for bleeding, how big the deficit is. And then there's more advanced imaging techniques that I won't get into, but you can see how much of that tissue is actually dead versus how much of it is salvageable. So those are numbers that they can calculate based on the timing of contrast dye that they inject. So they can see, is this tissue taking up that dye? Is it not taking it up at all? is it kind of taking it up, but it's taking a while for that tissue to perfuse. It's very cool, very advanced imaging techniques. So and there's criteria for and this has been shown in, clinical trials of deciding what patients with what amount of, brain that's been affected by this clot causing an ischemic stroke benefit from this intervention. Does that kind of, not everyone who has a stroke is a good candidate by any means for the stroke intervention, but I hope that kind of helped clarify that.
Yes, it did. And we have one more question from the audience regarding the technical side. You talked a lot about different technologies you use, and you showed us that one beautiful slide of the 3D models and everything. They're wondering how artificial intelligence will impact the outlook for radiologists and interventional radiologists, and if that's being implemented with you right now, or the future of that, what would it look like?
Yeah, that's a really good question. And I almost had a slide on that because I actually have one prepared for something else and I didn't include it. But in brief, it's here a little bit, and I would say it's coming a lot more. So, one concrete example that I can share is I was at 2 years ago, I was at the largest radiology meeting in the world. It's called RSNA in Chicago. And Philips, who's one of the big vendors of imaging machines, has a virtual angio suite. So how we, take those pictures, they come up on that screen, but what they're trying to work with is where you wear goggles and you can actually use the images are reconstructed in the goggles, and it's almost like virtual reality, and you actually navigate using these goggles that are integrated with the imaging, and in some cases they will take the preoperative imaging and put, and have that 3D reconstructed so that when you're trying to get to where you're going, you have an understanding of certain landmarks, like or certain courses of vessels. So that's something that I've seen in the display shop, that not in the real world. But one example I can give you of just kind of integration of modalities would be, we use a combination of reconstructed CTs with ultrasound guidance for certain biopsies. So, it's not necessarily artificial intelligence, but it's the merging of two modalities into, a space that you can then navigate a needle, which has a probe, so you can figure out where that needle is, both in the CT world, let's say, and the ultrasound world, because both of those modalities help you localize a cancer you're trying to target with something, with a probe that would treat the cancer. Maybe that was a little bit confusing, but and then also on the diagnostic radiology side, in terms of like interpreting images and not just saying, okay, that's positive, that's a clot, but interpreting the image and saying, okay, this is a central clot, this is a peripheral clot. And more than that, there's technology coming out in that space, but more than that, it's using AI to diagnose and promptly integrate a team of specialists to weigh in on what the best approach is, which I think is a really cool application of AI. It's not AI in the intervention, but it's AI in the triage and the swift treatment of, being utilized to facilitate quick treatment of patients.
Yeah, it's amazing. And it seems like radiologists are the closest thing we have to Iron Man.
Yeah, I think that's a good thing. Yeah. No, it's and the 3D, reconstructions are actually things we use all the time when trying to understand in three-dimensional space, kind of what, for example, an aneurysm. So I didn't show a case of an aneurysm, but an aneurysm is, let's say the vessel is supposed to be like this and it's outpouching, but these aneurysms can be very different shaped, and those shapes you can't really appreciate on x-rays, and x-rays is, fluoroscopy images. So by using 3D reconstruction, you can actually get a really good sense of the shape of those and what would be the best way to address fixing them. Yeah. Any other questions on the technical stuff? Guys, it's so cool, I'm telling you. and it's really cool. All right, so I'll keep going and we'll have questions at the end. So I saw on your like handout, I get shy talking about myself, honestly. But some of you might be interested in how you get there, and everyone has a very unique path. But in brief, as you mentioned, I went to undergrad at Vanderbilt University. I maintained a high GPA. I did molecular and cellular biology was my major. I would say by far the most constructive experience I had in undergrad was working in the same lab for over 3.5 years. I started the first day of my sophomore year, and I worked through the summer leading up to medical school. I graduated medical school, and I kept working in the lab until I started medical school. It was an exciting project, and just whatever. And anyway, and so that was in a basic science immunology lab and my advisor was an MD PhD. And to be honest, like none of this was planned. He was a dynamic individual that I met with, that I decided to do research with. And, it was really much, much later that I realized that, there are amazing mentors who are PhDs. There's amazing mentors that are MDs and the reverse. And by no means am I saying you need an MD PhD mentor, but what I am saying is that, him having, he actually didn't practice medicine anymore, but him having been a clinician, looking back, I thought I started to have an understanding of the human body and certain, huge lapses in some areas, but at least in the area that I was working in, and I was working mostly in septic shock and innate immune response in both mouse models and cell culture, I started to have a pretty deep understanding of kind of the state of the literature, and also as it applied to translating that forward into treating patients. So I thought that was an extremely constructive experience, and I would definitely recommend, especially for people who are like early in their undergraduate career, trying to navigate a way to finding a good mentor, and really with a clinical something. I unfortunately had limited shadowing experience. That's actually one of the things when you guys emailed me to do this, I latched onto this because I just got busy in undergrad and I didn't really know who to email, and I didn't really know what to do. And I ended up getting pretty lucky in medical school, finding my way to a career that I, am currently very happy in and plan to be very happy in, but I didn't do that much shadowing. And I just wanted to mention, like, my parents and other relatives, I have many relatives in medicine. So I realized that gives me a unique, perspective, probably an advantage in terms of understanding just some things about, the hospital system that, I don't take for granted. And I'm always happy to, I think it's so important to ask questions, because I think for people who are going through this without any family members having been in the field, it's probably much, much harder to navigate. And yeah, that's my, kind of my undergrad experience. Okay. And then I added this at the last minute. So I definitely don't want to be stepping on a soapbox right now, but in looking back in college and everything, I would say, sacrifice is maybe a harsh word to use here, but I would say that, you have to make some to get into medical school. And in my opinion, they're so worth it. I think we have our whole lives to be, yes, like I say, social beings, and college is just a tremendous opportunity, I think, to focus on your own learning. I think a lot of us in college, some aren't, but a lot of us are very fortunate that we don't have, that many external pressures as we'll have moving forward. And so I think if you're lucky enough to have that time to really focus on you and your learning, I would just recommend making the most of it. And trust me, your life doesn't end when you go to medical school. Your life doesn't end when you go to residency. Like everyone's still living, and we're all still being social, and we're all still having fun. So I would just, keep that in the back of your mind, because I definitely, I have some sisters who are in medicine, and myself, you have hard times, hard years, bad semesters. And I just think keeping the eye on the prize and knowing that these sacrifices are going to be worth it is huge, and should keep you, motivated in undergraduate years. I also, so I know that there's a lot of pre-med advising systems set up within colleges now. So there was one at Vanderbilt, and, and it worked out for me. I met with them, I got the letter, I did those steps, but honestly, my biggest mentors were outside of that program. So I would just recommend finding a person or some people that are kind of in the know and might be able to help guide you in some way. on your journey, and whether that's the pre-med office or someone else, like latch onto them, like these people should be here to help you, and talk to them as much as you can to, get support and get questions answered that you otherwise would have no idea about because you haven't done it before. So applying to medical school. So, okay, so we're still in my undergrad years. So I think, and many of you have maybe already taken the MCAT, and the MCAT's changed tremendously, I know, since I've took it. Have you guys taken it? No, you're taking someone who used to shaking your head? No. Okay, so this is my thing, and maybe it's just my thing, but I think planning of it is paramount. So, and what I mean by that is give yourself the time to do it and set yourself up well. And maybe that sounds so vague, but for me, I was working in a lab that summer, and I would work all day. I think I took 3-day weekends, most weekends. And I told them, I said, look, I want to be in lab this summer. I'm committed to staying here. I knew I was going to be focused. I sublet in an apartment. It was just me. But then I studied every single night and every single weekend that summer, and took 10 days off at the end to really cram it in. And I got there. So I know that there's so many more resources now that are available to help. And I'm not familiar with them, honestly. But I would just say, like, having a plan that is going to optimize your test taking is so important. And for people earlier in college, that definitely means planning out when you're going to take the prerequisites that you need before taking the MCAT. I doubled up on sciences my freshman and sophomore year. So I was eligible to take the MCAT after my sophomore year, which was early, but it was nice to get out of the way. Just something to keep in mind. Yeah, and I would say keep in mind the end goal. I'm sure it feels very far away, maybe not, but to me it did, and really the end goal is to become a doctor and help patients, period. At least for me, that was it. Like you can be open-minded when applying to schools. And, I know you guys just had a session, I think, on MD, DO. I can tell you we have tremendous fellows right now in IR, some of whom are DO, some of whom are MD, some went to schools on the East Coast, West Coast, high ranked, middle, none of that. No, first of all, no one knows. Second of all, no one cares. At least the patient, no one's asked me ever where I went to medical school, really, ever. Not a single patient. And more than that, you just need to keep your eye on the prize and be open-minded when applying, because I think that's super important. And these 4 years, they're going to feel long. They're going to go by like that. By the time you're done with third year, med school is essentially over. Maybe that'll change by the time you guys are 3 med schools. But be open-minded, because those letters after your name, but really the privilege of being able to treat patients is so worth it, I think. Okay, so I'll go quickly through this because I know that we're at the undergrad level, but some of this applies to even you guys, I would say, in terms of things that I did in medical school that helped set me up for residency. I would say shadowing, okay? Going to conferences. I really hope they start happening again soon. I think sometimes it can be hard to get the funding, get the time off from classes. But if you can find a way, even if it's just to attend, it's happening in the city that you're local to, you say, oh, I don't really know anything about urology. Oh, I use urology as an example. I just think of that sometimes. I'm like, oh, I just happened to get interested in IR. But what if I went to a urology conference and that piqued my interest? If there's things that happen in the cities that you're in, med students are always, from my understanding, it's free for them to go to conferences. And these conferences sometimes are really nice and they're grand, and there's so many sessions and there's great podium talks. I would just recommend going and seeing as much as you can as an undergrad and also as a medical student. And also finding older students that you mesh with to seek advice, kind of just like I spoke to before. I found a few people on the way, and I don't even know if those people know that I feel that way about them. But there was because it's not like I was best friends. I wasn't going out to dinner with these people, but there were a few people who I really looked up to along the way, who when I really, had a question about, oh, what should I do here? Like how would you approach this? Or do you think I should, take this class or and maybe that seems like a small decision, but it can really affect kind of how your semester goes. And that semester is, 1/6 of what you apply to medical school with. So I would say when you find people that you look up to and trust, latch onto them and seek advice, and they should want to help you. And usually it's really easy for people to just say, hey, this is what I did. This is what worked for me. if you're like me, this might work for you too. And in terms of going to cases, it applies a little bit more to medical school, and we can talk later about, you know, what people are doing now in terms of college experiences, in terms of shadowing it in the OR. It's not something I did, but I know students who have done that. But I would say in any kind of clinical experience you have, just be as available as possible. I was always that girl who was like, call me in if there's a cool case that goes this weekend, like, call me, I'll be there. You know, I want, and through those small experiences, I learned so much. Like some of those cases that I went in for when I wasn't even on call as a med student, which doesn't really mean anything anyway, you know, are some of the cases that I learned the most from, and it shows initiative. And I would just keep that with you. If you get in the headspace of, okay, I'm active, I'm ready to be there, I'm ready to put on my scrubs, my clogs, and show up with my scrub cap, that I think is just a really good way to be. Okay, so I'm finishing up here, but maybe you guys are wondering exactly how many years this takes. So like, honestly, like, don't think about it. But if you want to think about it, or I figured I'd just show it. So 4 years of undergrad, okay, this is generally speaking, 4 years of undergrad, 4 years of medical school. You do an intern year, okay? That's like, you know, Grey's Anatomy, surgical intern, first year. It's really nothing like that, but actually it's a little bit like that. You know, you're a general intern for a year. And then you go to your radiology training, or you go to your specialty training. And so for radiology, it's 4 years, and then you have a fellowship year. So it's 5 years total. And this is changing. I'm actually doing a 3 and 2 program. So I still have these 5 years. The 3 is diagnostic, and then I have 2 kind of fellowship years. So this is not something to think about now, but this is just to give you a general overview of the path that I'm on, if this has any interest to you. And I would also say, you know, I wouldn't think in terms of how long it's going to take you to get through when you're thinking about if you're going to follow through with going to med school, what specialty you want to go to, because it's really not a race. None of this is a race. And if at the end of all of it, you are in a specialty that you enjoy and you're helping people and you think you're utilizing skills that you're good at or skills that you've harnessed, that's the most important, you know, like, period. Yeah. Okay, and this is too much info, but this is essentially, you know, PGY means postgraduate year, okay? So just not to keep in mind now, but there's a bunch of different paths to kind of get to many different specialties. Some of within radiology, IR. I didn't really talk too much about diagnostic radiology, but IR is also a field that if you go in thinking you want to be a diagnostic imager and later you are interested in interventional, you can say, okay, I want to, you know, intervene on patients. I want to, you know, do those cases. You can then go and get additional training afterwards. So it's not something you necessarily have to wedge yourself to from the beginning. Okay. So as I mentioned at the beginning, even though training feels like forever, it's going to take forever and we're never going to finish. Trust me, it kind of still feels like that now. The majority of the time we're going to spend is going to be out in practice. So without boring you with like details of things that you might consider more later down the road, I would say that IR is awesome because it's like highly variable. And to me, that was like a really attractive thing about the specialty. You can go into private practice. You can go into academics. You can be research focused. You can have industry partnerships. You can, you know, the cases I presented at the beginning, like some of those were really high acuity cases, right? So those would be most found in a like academic medical center where they do a lot of these big cases. You have a lot of interventional radiologists working together, they're partners, and they cover, you know, like when big cases come in, they cover for each other. They still do the scheduled cases. And yeah, or you can work in an outpatient center. So those would be cases like those Portacaths and some other, you know, venous work and even cancer treatment can be done as an outpatient. So really, depending on how much, you know, if you love the hospital, you love being in the hospital, you can do that. If you love, you know, want to do outpatient, more office hours, more small cases, you can do that. If you want to read cases, a diagnostic radiologist and do procedures, you can do that. And so I think that's one of the things that's very attractive to me about the field of radiology in general is the breadth of how you can practice, and which can change as you go through your life. Because what you want at 40 might not be what you want at 60, but if you still want to work at 60, what you're doing might look a little different, which you really can't say that about many other specialties. Okay. And that's it. That's actually all I have. So I hope that was helpful. I hope some of those cases were at least a little bit cool. And with that, if there's any other questions, I'm like so happy that there's people like you guys setting this up, because I hope someone watches this and maybe emails me or asks me what it's like, or even if it's something I don't specific to your case or what you maybe want to do or your CV or how you want to apply. Like I'm no expert in that, but I'm happy to give my free advice. And I just find this to be such a rewarding career. And in the same vein, I think would be really rewarding to, as I'm a little further along, start helping people who, as we talked about before we started, who are a decade younger than me, which is just crazy. So I'll conclude there.
Thank you so much. That was honestly an amazing presentation. And I know you said earlier that you were hoping that this would like influence at least one person to really look into it. And I want to say your goal definitely has been met. I've seen the light per se. I had no idea that like this even existed. And
I'd like to hear.
Yeah. So we do have a couple questions from our audience. They want to know if you rotated IR during med school and how, or just broadly how you were introduced to it.
Yeah. Great question. So I had a bit of an advantage because I didn't talk about it today, but I did a PhD. So it was actually during my PhD years that I was approached by a clinician who knew, actually, let me start again. How I started. I had a friend who was a couple years older than me, and she started talking to me about radiology. We were at some like sporting, we were like playing like flag football between the classes. Like it was a funny med school thing. And I literally was talking to her in the locker room. I was like, hey, like, what are you going into? Blah, blah, blah. She was like, hey, like, I'm actually meeting with the chair of radiology. I'm really into radiology. And I was like, oh, like, we have a big imaging institute. Like, I know I've met some of the radiologists. One of us gave us a really, to the point, awesome talk. And so she was like, you should just email the chair of the department and set up a meeting. And I was like, really? And she was like, yeah. She was like, he's really approachable. He's a new chair at the institution. He loves engaging people from the beginning of their careers. And it's exactly what I did. I literally emailed him and said, hey, like, and I had like, a funny, not funny CV, but like I had who I was put together at that point in time, which was me as a second year medical student. And I put that together and sent it to him and said, hey, I'm looking to do research. So I obviously took many years off to do research, but this definitely applies to people who want to do research during med school, take 1 year to do research, whatever. That really, and I met with him and I said, hey, like, this is what I'm interested in. I think like I didn't sign any papers. I didn't commit to the field, but I really, to answer your question directly, my interest began with a meeting with the chair. And then I was approached and he passed along to his colleagues. He was, a great advocate for people who, showed at least even a little bit of interest. He passed along to one of his colleagues that I was maybe interested. That colleague approached me and said, hey, do you want to work on this research project? One thing led to another. I went to the national conference in 2015. Okay, so long ago. 2015, didn't even present at that conference. I just went because I had started working with some interventional radiologists on some projects. I ended up presenting the next year with an oral presentation, but I just went to the conference in Atlanta. I drove there from Nashville to see what it was all about. And I was just like enamored. I was like, whoa, I can't believe like all these people do this thing I never even heard of. I can't believe like they all know what each other are talking about right now, because this stuff is just so insane. I thought I knew stuff. I was a second year medical student. I had taken step 1. I was like, and it turns out, nothing. No, I'm just kidding. But it was, I'm being a little roundabout now, but it was a combination of a blind email to someone who, I had heard was very supportive of individuals interested in the specialty, and going to the meeting, which was, prompted by some work, some research. And this research was, retrospective, case-based stuff. It wasn't anything. It was definitely something that if you were staying in med school and didn't have time off for research like I did, you could absolutely accomplish. But I think it's important to go to those meetings and just see what they're about. And if you can present at them and be that medical student, like don't be that medical student, you can. If you want to be that medical student who just mines data and gets involved and sees stuff, that's great. But if you can be that medical student who gets some mentorship from above to actually submit an abstract as a first author, that's like awesome. And the earlier in medical school that you find someone that maybe wants to, work with you, and you can ask me, details about that. That's just a great launching point to understanding how, just essentially about how specialties work. And I always told myself, I said, IR was really cool. I got exposed to IR very fortunately very early in my training. But when I went through my clinical rotations, this was before my clinical rotations, I told myself, I said, be open-minded. What if I had been approached, I was honest with myself, and I was like, gosh, my interest in this field is really just based on some kind of random series of things in one meeting that I went to. And I'm sure other specialties have just as cool of meetings and do really awesome stuff. But at the end of the day, I was like, IR is really freaking cool, and nothing, there were some competitors, but ultimately I stayed the course. So I would definitely say everyone's situation is unique in terms of how you want to approach this. I don't think every, chairman should be, they might, blind email and say, hey, I'm interested. But depending on kind of where you are in your training, and what institution you're at and who who might be able to connect you, just leverage those things. And if you have questions, like ask, be like, hey, what would be appropriate? Like, because you want to be like an informed individual when you and they don't, a lot of people, much isn't expected of medical students often, but if you can be a little, read up and informed, and that often takes guidance from someone who's been there before, maybe a year before, 2 years before. Find those people, like get the scoop.
That was a beautiful IR love story.
No, I don't think that was too long of a story, but
no, it was great. It was
yeah, great. It's just like, I don't know. I just wish you guys could just all come to the meeting. I mean, it's a really cool specialty, but truly about for any specialty, regardless of what you think you might like. Like I would say, just when you start medical school, when that day comes, it's gonna come. When you start medical school, just find one thing that you're like, I think I could do that, and then see, okay, what is on like a national level or on a city level, like what do they do, where do they organize, like what are the big topics in that field, like what's new and happening in that field, and use that as a launching point. But yeah, IR is really cool.
I was surprised and really impressed with how dynamic IR is in cancer treatment and also in cardiology. How closely do you work with oncologists or cardiologists during like some of these imaging events or
like very closely? So some of it happens at the acute level, where we have chats that that are attending, the bosses text about what's the best course of treatment. So in that way you're intimately connected with all of the relevant individuals to a patient's care on a very quick basis. But like a good example would be this Thursday. Yeah. So we had tumor board this morning. The sound tumor board sounds like it's a bad thing. It's not. It's literally where patients who, I'll just like take you through an example. This is like no one specific, but just an example. Say someone comes in with belly pain. Okay. They get a CT scan. They see something in their liver. They actually end up just like having, the belly pain goes away, but they're like, you need to see someone about this liver. This could be something, it could be like an incidental finding that needs to be worked up. They go and meet with a liver doctor. That liver doctor decides, okay, do we think this needs like tissue? And who gets that tissue? IR can get that tissue. Does this tissue come back cancer? Is this tumor something that IR can treat? Oh, okay, it will come to us again. Or is this something that we could actually just surgically resect? Okay, they go to the liver surgeon. So we actually have office hours, at least at the institution I'm at the same time as the liver surgeons and the liver doctors. So quite literally, when these patients get referred to these either liver medicine or liver surgeons, and they think that something that we can offer is the best course or a course, we go and meet with them, we introduce ourselves, and then in a very kind of stepwise way every week, we talk about all of the patients that have come through that week and make a final plan about what the best treatment is. And at those meetings, you always, office hours are a very, fluid thing, and we're always all running around, meeting, because it's so important to kind of make a face for yourself, even if it's just a, more or less brief introduction. But then when we sit down at tumor board, we show the imaging, the oncologists are there. They're the people who are up to date on the clinical trials, the standard of care. You have the liver surgeons, you have the interventional radiologists. Who else do we have there? Lots of people, like transplant medicine, and some of these people might go on to get liver transplants. So that would be, I think, a beautiful example of the teams working together to care for patients the best. And it's awesome being able to work like that, because I love meeting new people, and people are just, I don't know, it's just a great group of people. And I even at my, when I went to medical school, we had a tumor board too, and it was full of it's awesome to meet people from other specialties. They have very different personalities sometimes. They have differences of opinion, and the back and forth is not argumentative. It's all just constructive, truly.
We're running a little bit tight on time, but before you go, a little tradition here is, what is one piece of advice you would give your younger pre-med self if she was standing right here in front of you right now? What nuggets of wisdom, what things to help guide her journey, or anything you would like to, say to her?
Okay, tradition. Let me see. I would say I think I would tell myself, so college self, I think I would tell myself that, because I'm happy where I am, I think I would tell myself, don't feel bad for yourself. This is an awesome journey you're on, and go full speed ahead. It's a privilege to be in the position you're in. That's because I truly feel fortunate to have been via serendipitous and just events native to my life experiences, to kind of be on the path I'm on. So I don't know if that's not specific enough, but
no, that was great. And I want to thank you for such an amazing presentation. You answered so many questions, almost like you're reading our minds, really calmed us all down, because I know we're all feeling that type of anxiety right now, especially with COVID. It's all amplified. So I want to thank you. That was amazing. And for our audience, we just put in the form in the chat. Make sure to take your time and answer those questions and reflect about what she said, and really take your time with that. We'll be back next week on Wednesday with an OMFS surgeon, so make sure to come out to that. Make sure to subscribe, join our LinkedIn, email Serve, and definitely make sure to follow her on Instagram.
Yeah, right here, guys, right here.
Right there. Make sure to follow that Instagram. It's great. So we hope to see you guys next time, and enjoy the rest of your night.
Thank you guys so much for having me.